Hello and welcome to the Royal College of Pathologists Guideline Implementation webinar. My name is Peter Johnston and I'm the Vice President for Workforce and Corporate Engagement at the College. I'm very pleased to be hosting this webinar today where we have experts and authors of the dataset for histopathology reporting of prostatic carcinoma. These are updated guidelines and the authors are here to present some aspects of the guideline that members may find difficult to implement, and along with practical tips and/or clinical scenarios. They'll also be available to answer your questions. I'm pleased to introduce you to today's speakers and authors of the dataset. First of all, Dr. John Oxley, who will be presenting today, John Mitchard, who will be here for questions and answers, and thanks also to Drs. Richard Colling and Vidhya Manohar, who were involved in the writing. Before we start the webinar, I would just like to remind you that the presentation lasts about 15 minutes or so, followed by a similar time for questions and answers. All the participants are muted, so if you want to ask a question, please do so using the Q&A function at the bottom of your Zoom control panel. We'll be doing that after the presentation has finished. And so without any further ado, I would like to start by welcoming our speaker, Dr. John Oxley. Over to you, John. Thanks very much.
Right. Well, thank you very much for that introduction. Hopefully you can see that. So I'll just take you through.
All good.
Thank you. And I'll take you through a few slides just to refresh ourselves. Why is that not good? So the last data set was published in 2016. And since then, we had the PROMISE trial published just after that, which was looking at MRI-targeted biopsy. So we've moved to that, as well as LATP replacing template and truss biopsies. The WHO book was published a couple of years ago, and that also made some minor changes. And then the ICCR dataset and also the role of clinical prognostic tools have come into use. So these are the subjects which we tried to look at and adapt. So we didn't do a complete review of all the subjects. We went out to consultation with subjects we thought were important, and then we concentrated on those. So the biggest move, which most hospitals have moved to, is local anesthetic transperineal biopsies. And there is a training program which most urologists or cancer nurse specialists or radiologists go through in order to train to do this technique. And from our point of view, it's a great opportunity to get them, feed them back their results and get them to use a standardized requesting thing, so that what you don't want is 3 different operators using 3 different systems and submitting the calls in 3 different orders. It's causing chaos. So because they go through a centralized training program, that's a process where you can get them to do the same thing all the way through. Now, it's not brilliant, but if you teach them to give you this information, then it will save you a lot of time. So an example of this is put into the data set, so you could use this as an example. But I think the most important thing we try to emphasize is that the operator's name is placed onto the requester, so you can directly feed back to that operator the quality of their calls and what the information they're giving you. So the WHO Blue Book made minimal changes in prostate. It was mostly obviously around the renal tumors and things like that, and it provided no real clarity on how to grade intraductal carcinoma due to the differences between GUPS and ISA. It sort of fudged it a bit. So hopefully there'll be some more guidance on that coming soon. So the ICCR data set has been published. This is the international one, and it offers 2 types of data set, either a case level or a specimen level. So each specimen would have a small data set attached to it. We would strongly advise you not to use the specimen level data set. It's far too laborious and it's not really required in the UK. But most importantly, we went about writing up this data set in a reverse order. So we actually went to the urologists and asked them what they wanted out of the pathology report. And what's loud and clear is that more and more people are using this predict prostate path tool, which is available on the web for free. And also the fact that we're moving away from the D'Amico classifications to using their Cambridge prognostic groups. So you can see that this is a screenshot of a predict data set which is requested, and you can see there's lots of data available in here, and hopefully we should be providing this data to the clinicians in order that they can perform this analysis for their patients. And the important thing which you may notice or may not notice is that there is no tumor length or percentage or anything like that in this data, which is quite critical for our further conversations. So the other thing which has come up is a sampling of TERPs, how many chips to put in and how much to do this and how much. And this has really come about. Quite a few places use a sort of a sampling, first 10 grams and then 1 cassette for every further 5 grams. But the problem is that we're now getting HOLEPs. These are these laser morcellerated prostatic cystic tissue, and you can get up to 100 grams. And that was leading to some centres embedding 30 blocks of prostatic chips. So we looked at this particularly. There is a paper which is out there which said that 18 cassettes detected all prostate cancers, but 10 cassettes would pick up 96% of tumours. So it might be a suggestion if you haven't moved to a smaller sampling, that then do an audit yourself and see if you can drop it down to 10 from 18. So really, I wanted to summarise what's in and what's out. So what's out is complex measurements of tumour burden. So I've emphasised that the predict basically uses the number of cores involved, but doesn't use tumour lengths at all. But the longest length of tumour is used for correlating with radiology and for focal therapies. So often the PROMIS definition of a significant tumour was a 6 millimetre of Gleason 6 or any Gleason 3+4. So that data is useful for the radiologists for their positive and negative predictive values. But what we really should be doing is weaning the surgeons off extensive data like percentages and whatever. So we just want a longest length of the tumour in that specimen, in the whole specimen. You don't need to do it at a level of the specimen level. And that's really up to you, but there just need to be a single measurement at the end. And if the surgeons kick up a fuss, and then you can just point them in the way towards the predict model and say, this is the data you should be using. You don't need any of the other data. So cribriform growth pattern, this has crept in. It's most centres, I suspect, are putting this into their reports. Now the definition is out there. We list it in the data sets and references, but there is massive inter-observer variation on how big, how many holes, how many this, how many that. And this is something which is hopefully going to be clarified in the next couple of months. There's a ISUP meeting at USCAP at the end of March. So hopefully they'll come up with some guidance as to what we should be doing. As with intraductal cancer, it's exactly the same. So both with cribriform and intraductal, we should be avoiding active surveillance. There's no real clarity in the WHO book. And my advice and our advice in the data set is we should be grading it as per the ISUP system. So with calling it pattern 4 and areas of necrosis as pattern 5, and to include it in any tumour measurements that you do. But in the cases of IDC alone, which is incredibly rare, then you need to do immuno, but immuno is not required to differentiate between intraductal and cribriform in a standard setting. I mean, you're going to see a lot of IDC and a lot of cribriform growth patterns in high-grade cancer tumours, which it is of no use really. In what you're trying to do is stop people from getting active surveillance based on this. So Gleason pattern 4, the percentage of Gleason pattern 4, again, this is enable people to manage 3+4s with low pattern 4, percentage of 4s could go into the active surveillance. And I think it also helps concentrate the mind a little bit. If you have got a 3+4 and a very, very small amount of pattern 4, then you need to be able to mark it and say that is the pattern 4. Whereas in the past, you may have seen a 12mm length of tumour and thought, well, I'm sure there's a bit of pattern 4 there. I'll call it 3+4. So now we want you. Now there should be instances where you'll be putting 3+4 with less than 5% pattern 4, and they could be suitable for active surveillance. At the other end, at the 4+3, 3+4 threshold, it's probably worth writing some sort of comment on that, saying this is a borderline case, but I favour this or that. So the other thing we brought in is really a representative block for genetic testing. Now, this is new to uropathologists, really. We don't do much molecular testing, but it has come in with BRCA testing for patients with hormone-resistant metastatic prostate cancer. And what we don't want, and when I've been involved in looking at how to streamline this process, one of the big holdups is the pathologist reviewing the material to decide which block is suitable. So we want this to remove that block by placing it in all your reports of tumours to state which one is a representative block, and also the percentage of tumour nuclei within that sample. So it's tumour nuclei, not of tumour. So if you may have a tumour percentage of 50%, i.e. half the cause involved, but as the rest of it is stroma and very low nuclear, you're going to get a higher percentage of tumour. And that's really it. That was a bit quicker than 20 minutes, wasn't it? But if there are any questions, I'll hand back to Peter and he can...
Thank you very much, John. That was really interesting. I guess my first impression is that what you've done is, in some ways, make this more straightforward, with less opportunity to confuse things and record inaccurate data, which I think it's not that it's a simplification, it's about what you're using is improved and has got more evidence base behind it, which I think is, that's really helpful and sensible thing to do. Am I right in that assumption?
Well, basically, pathologists are attempted to measure everything to the nth degree, and many reports say, 23.26% tumour, and we're trying to get everyone to stop doing that, realizing that data is never going to be used by the clinicians in any model, prognostication model. The thing is, we can measure pathologists can measure anything in enormous accuracy, but if that data is not actually being used, then it's completely pointless and wasting everybody's time. And we should be getting down to reporting prostate calls in a matter of 15 to 20 minutes max. And to do that, you need to cut down the amount of accuracy. And you are sticking a prostate needle into a prostate. Who knows if you're actually hitting the tumor or not? The MRI is going to give more information from that point of view than we could ever do with tumor volume. And I think that's what's changed. The MRI is now giving us a visual size of the tumor, whereas before MRI we didn't have that. So we were given these complex percentages and patterns in order to sort of act as a sort of a predictor for the outcome. But we've got MRI now, so we shouldn't be needing to do this. Thank you.
There's a couple of questions in. One which is a question that I thought of as you were going, which is that we've abandoned the percentage of involvement of cores. Have you done that yourself? And what are your tips for weaning the surgeons off this piece of information?
It was very, very simple. I just emailed them and said, we're no longer providing percentage of tumour. As we'd moved to a digital, and prior to that, we would mark on the slides and then do a visual overview of the percentage. But of course, you can't really do that digitally because we don't have, our digital system doesn't have that. But if you're not moving to digital, I would seriously say, this data, you do not require this data. I'm giving you longest length, and drop them my email address. I'm more than happy to discuss with urologists that by not doing this percentage, I can report an extra set of prostate core biopsies an hour or something like that. You've just got to say to them, I cannot cope with the number of prostate calls that you are sending me without stopping this. And I think that we're all going through a horrific waiting list initiatives with, 20 sets of calls being done at the weekend and then landing on us. So we have to cut down the amount of information that is really not useful, and then point them in the direction of the predict study and ask them a predict protocol and ask them, are you using this? And if they say they're not using it, well, you should start using this, and I'll give you the data to provide you this, and go back. But we have stopped percentage. We've not given a percentage for 2 years now.
I think as well as being simpler and quicker, it's also more informative in that you don't run into the discussions about, well, this core's got a higher percentage of tumour, but it's much smaller than a longer core with a lower percentage of tumour. So the volume of tumour in that core is actually greater than one with a higher percentage. And I think it's a far more reproducible and simpler measure to give.
And the MRI's replaced all that data, so you shouldn't be doing it. You shouldn't be doing percentages. It's rubbish. None of it makes sense. And also, there's a recent histopathology publication looking at all the different how you measure tumour, and it showed that percentage was by far the worst, and we should be doing linear lengths.
Thank you for that. I mean, there's a couple of comments which are just supportive of the time wasting that's spent on making measurements that are spurious and have no great clinical value. And I think if you look at how we might consider diagnostic stewardship going forward, how best we use our resources, being critical about what is worthwhile is really valuable. So I think it's a very useful example for people to have in that regard. There's a couple of detail about reporting, and one is saying, are we using PNI, which I assume is PIN, but I may be wrong there. And the other is, are we still giving TPC in reports? Forgive me for not being able to translate that into...
I presume the PNI means a perineural invasion, and the answer to that is yes. We haven't managed to wean the urologist off that. Some of them still like to think that that's useful for them, in so much as doing a nerve spare on one side or not. In the radical prostatectomy. So we haven't managed to get rid of that. It's a little bit of a waste of time. And then the other one was TPC. I think that's total percentage of cancer. Now, this is I think it's still possibly in the national prostate cancer audit data, but basically stop doing it. Just stop doing it. And if your clinicians complain, you say, oh, you should be giving this for the national prostate cancer data, and you say why, and again, forward them my email, and I'm more than happy to take it up. I mean, the problem is that the national prostate cancer audit has no pathologist within the team, so they are working in kind of the void of not having any good information.
And also now in the days of targeted biopsies, the total cancer percentage is slightly meaningless in that you're going to be overrepresenting the tumour in the targeted biopsies, and so you will then give a falsely high estimate of the proportion of cancer. So,
which is the whole point of a targeted biopsy, of course, is to get the diagnosis, not the percentage. Yeah, I mean, I can report a first actually on this webinar, which is a comment from somebody who says, you have no idea how this has cheered me up today. Always thought this was wasteful of our time. So cheering up in a webinar, that's a first, guys. So congratulations on that one. Thank you very much. There's a comment about doing 20 LATPs over the weekend. So it's really one directed at the college, which is, can we work with NHS England to explain the difficulties and the uplift of activity that arises? Well, all I can say is we're doing our very best to interface with NHS England. I think NHS England at heart appreciate the difficulty that we have in terms of being able to deliver service as pathologists across the country. However, the bottom line at the minute is there is really nobody putting their hand in their pocket to improve the investment in diagnostic services as a whole and pathology services in particular, and cell path underneath that. So we're all struggling against that. And I think, in fact, the argument seems to me to be shifting more towards the NHS and the Treasury rather than the professions and NHS England. So we're doing our best. There's a consistent series of lobbying going on with various people. The Academy of Medical Royal Colleges is involved. So the Spec Socs are also busy with all of this. So there's a consistent effort being made in this regard. So successes cannot be guaranteed, but please keep asking us to do that, because it helps us to be able to say we have a group of people, a consistent request that we're doing this. And remember that the college is not what the people in Ailey Street say. The college is us, all of us. And if there are issues which impact upon us, please communicate those, because that gives us strength to do more about it. So that said,
I think
sorry, go on.
I was going to say, in situations like this where you are getting lots of biopsies over the weekend, I know we are, I think it's important to talk to the clinical teams and manage their expectations as to how long it's going to take for those results to come through.
Yeah, thank you. Just a quick one, really picking up on the comment about perineural infiltration. Do you comment on lymphovascular invasion in the cores?
So it happens so infrequently, and it's probably got limited import really when you get a set of prostate cores with LVI. I can't remember if it has dropped out in the data. I think it has dropped out. It's an optional thing to put in, but we haven't put it in because you'll be putting no for 99.9% of your tumours. And then the one which has actually got it in, it's probably going to be Gleason 4+5 and high grade and metastatic. So it's of no real clinical use. So it has dropped out of the cores, but it is still there for the radical prostates. But again,
whereas perineural isn't in the radical prostates, is it? Because
no, I don't think it has, because it's pretty omnipresent.
Yeah, it's more exceptional when it hasn't got perineural invasion than when it has.
So there's a question about lengths of, a couple of questions about numbers and lengths of cores. So somebody says, we are giving the number of cores involved, and what is your take on the reporting of the length of the length of tumour in these cores instead of percentages?
So I think
you tackled that, but
I just wanted to emphasise that really. So the very first form we said, which was asking for the operator person's name, I think it's really important that we have a two-way conversation. I mean, certainly from our point of view, we have a keen urologist who's sort of leading the prostate sampling, and they're the people who you need to connect to. And then you need to get a standard of what quality cores you expect from this person, train them up to say, these are your cores, this is what I want. And then when you get a set of rubbish cores, you email that person and the person who sent you the cores and say, these cores are unacceptable, they're fragmented. Because the problem is it's estimating the number of cores involved when you've got 6 pieces and then they only sent 3 cores. It's problematic. So I think we need to actually train the urologists, and they're much more receptive if they're beginning their pathway of learning LATP. In the old days, you couldn't engage with them, but these days there is engagement, especially if the nurses as well are very, very, you can engage with them much better because they take feedback a lot better than doctors, I'm afraid to say.
So if we can just continue this discussion for a little bit longer about cores and their interpretation. There's a couple of questions about the sort of biopsies, and are we giving up? Is there a national move away from sextant to targeted biopsies? The answer to which I think is probably yes on what you've said, but at the same time, somebody else is saying, should we really be telling the clinicians that we just want targeted cores rather than those of a more random nature? What's your approach to that?
So the evidence out there for pure targeted cores and no systematic cores is not conclusive. Certainly there is some evidence to suggest if it's a Likert 5, so basically high risk of cancer, then you could probably skip the systematic cause. Likert 4 is a little bit borderline, and Likert 3 you couldn't because there's no real targeted lesion to spot. So some centres are dropping down the numbers of systematic calls. Certainly in our centre, we started off doing 9, and then 3 for the target. And then if there's a strong target, they'll probably only take 4 on one side, maybe 5 on the other, and then a target. So it's varying, and there is a little bit of movement in this, but I think it's not all there yet. So pure targeted calls for Likert 5 are acceptable, I think, but not for lower Likerts, I think. I suspect. Obviously, if there's a PSA of 200, it's a clinical diagnosis of prostate cancer. You shouldn't be getting systematic calls, 18 calls on someone who's got a PSA of 400 and blah blah blah. But they shouldn't be doing that. I think what we're trying to encourage people is that you should be getting no more than 18 plus 3 targeted. But again, evidence is out there. So there's in the data set, we talk about getting it right first time guidance. That's out there. If you're getting too many calls, or you're fed up with somebody taking 30 calls, and get that information, forward them that document. This is produced by urologists. You should be using this system. Stop sending me 30 calls. It is not required. And just, again, copy me in. I'm more than happy to take this argument on with urologists. But there are some very powerful people in the urology world who are trying to encourage less biopsies to decrease the workload on pathology. They are supportive of us, but some others don't really listen to them.
Yeah, the core biopsies are certainly there's a consistent series of questions coming in around them. Somebody asking about fragmented biopsies and what do we do with them, and somebody else asking if we have 6 biopsies from different sites, do we Gleason score each one of them or grade it for the whole case?
Okay. So fragmentation occurs by the urologist, by the laboratory, and at various stages. If you're getting a lot of fragmented cores and your cores are not very good, you need to speak to colleagues in other trusts nearby and ask them their quality of cores. And then you need to go all the way back to the urologist and see how they're taking the cores. We're trying to look at this around the country in a couple of centres at the moment. So hopefully we'll get some information on how some centres have really good calls and some centres don't. It's not all down to the urologist sending us crap calls. So fragmentation is not necessarily the urologist's problem. It can be the lab and how the calls are sent to you. So if you have specific problems, you want to improve your calls, I'm more than happy again to give some guidance if someone drop me an email. What was the other question?
It was about should we grade all of them?
No, definitely not. You shouldn't be giving individual grades for individual regions. Again, I would urge anyone who has a problem to go and see a set of calls being taken. Okay, so they're using a needle, very long needle, to hit a walnut, and if you actually believe, guided by a black and white fuzzy little image, if you believe that they are actually different tumours in different areas, then you're kidding yourself, and they're certainly kidding themselves that they're getting different tumours. So I would definitely not. We personally grade all the right calls together, all the left calls together, and the targeted calls. That is not a data set item. Okay, that's what we do. But you should be providing a bottom line prostate a grade for the overall tumour Gleason grade, whether that based on the targeted calls or the right calls or the left calls. But don't do an amalgamation of all the grades, because that targeted thing is probably the most important grade to give. And the other ones are probably just going to be Gleason 3+3. So if you've got a Gleason 4+3 in your targeted calls, but you've got a lot of pattern 3 in the other right and left calls, don't decrease it to 3+4, because it's going to be the targeted is going to be the most reliable. So a bit of common sense, but certainly don't Gleason grade every single core. That would be madness.
I think we avoided being too prescriptive on this in the data set and said that we couldn't give a one size fits all, because certainly in our centre we're a HIFU centre, so we do actually give an overall Gleason score for each of the sampled sites, but it's fairly quickly done, so it's not onerous, and the clinicians seem to like it.
Okay, there's another couple of questions about cores. There's also one in about radical prostatectomies, which we'll come back to because it's not really the dare I say it, the core business of this webinar, but we can come back to it. And there's also one on BRCA, which we'll come to. So I mean, it's just a couple of questions about cores again and length of cores. So there's one which is giving the longest length of cancer, or do we give the longest length of cancer? But do we include the intervening benign prostate in the midst of that when we're doing it? And the other one was about, again, the length of the biopsy, and which I can't find in the meantime, but it's the same sort of deal as exactly how much of the core do you count as, or what is the length? Is the length of the tumour or the length of the core, essentially, and how do you work that out?
I think the evidence regarding the intervening benign stroma is pointing to the fact that if you've got discontinuous tumour in a core, it's far more likely to come from one spiculated focus where you've sampled the benign tissue that it's insinuating through than that it is that you've hit two small foci of tumour. So what we do is give a length, so from one end of the cancer to the other end of the cancer in the whole core, and then state whether it's a continuous or a discontinuous focus. There's no agreement on what constitutes discontinuous. Some people use 2 millimeters, some people use 3. I've even heard some people use 5 millimeters. But I generally myself use about 3 millimeters to say whether it's discontinuous or not.
And then there's a recent paper by Dan Burney which basically said that it didn't make much difference. In most of his thing, it didn't make any difference whether you discontinuous or continuous. The length of the tumor within a discontinuous fashion gave the same results. Certainly, it's something to look into. I mean, personally speaking, we use a 3 millimeter cutoff and state whether it's discontinuous or continuous, but that's still out there for consultation. We'll find out. I mean, 5 millimeters sounds quite good actually, because that will probably crash out a whole load of them, because that is quite a distance to split. If you've got a 10 millimeter core, then not many of them will be discontinuous over a 5 millimeter thing. So personally speaking, give the longest length and then state whether if it was a discontinuous when you're using a gap of at least 3 millimeters, I would say, because often you'll get little splodges all the way along and you'll be saying it's discontinuous in every single case, and that's not quite as important as you think. It's what we worry about is that you've got a little blob at one end of the core and a little blob at the other end of the core, so the actual continuous length is only about 1 millimeter, but you've got a discontinuous length of 13 millimeters. So they're going from a active surveillance category to a treatment category. But again, it needs to reflect on the MRI. You've got MRI now. We know how big the tumor is. If they can't see the tumor and you've got a small discontinuous focus, then that sort of supports more active surveillance rather than treatment.
Okay. Thanks very much. I'd like to just change the focus for a minute and look at some prognostic things. The first is really about BRCA. And somebody said, would it be possible just to go over the molecular testing for BRCA again, and how you assess the tumour from molecular testing?
Okay, so BRCA is being used as a screening thing in castrate-resistant metastatic prostate cancer, and if that 10% of them have been shown to have the BRCA mutation, and then they are suitable for other therapies, which I cannot remember its name. It begins with P.
Olaparib.
Yeah, that's it. Does it begin with P? Oh well. Anyway, they can treat it. So that is why they're asking for BRCA testing. Now, the problem with that is at the moment, most people are requesting BRCA testing when the man has already got castrate-resistant prostate cancer. So the clock is ticking down, really. They want to do treatment, and it takes about 3 or 4 weeks to get a BRCA result, which then is normally negative. So then they're further ahead. So there's some pressure to actually BRCA test patients with high-grade disease up front. So that is what's in the pipeline. From the point of view of assessing tumour quantity, you'll be glad to know that I've tried to negotiate with the EQA group to include assessment of this in the next EQA, the prostate core EQAs, as a non-mandatory and non-scoring part, obviously. But in that email, which will go out, there's a little bit of guidance of how to do it. There is some stuff out there, something called Gen QA. There's a webinar by them on YouTube, but it's not particularly helpful. But there is some links to some further usage. So it's only really useful when the genetics are looking for amplification of certain genes, because they need to know how much tumor is in there to see if the amplification is true, and whether it is actually a true negative result. So if you have a low percentage of tumor and they get a negative result, that might be a false negative. And that's why we're giving the information. And if you are uncertain about doing this, it's not you, then do speak to other teams in your department, because I can tell you this has been going on in the lymphoma gang and the lung team for years. So we are just behind the curve from this point of view.
Yeah, thank you. I mean, I think you're right. It's the difficulty is always that the clinicians tend to believe what the genetics say, no matter what we say, which is a little bit irritating at times, but because it doesn't actually change what we've already seen by and large. So I think it's important that it all goes into context. The other prognostic thing that's around is that what's the relationship between, or the difference between, perineural and lymphovascular invasion. You said earlier, John, that if you've got lymphovascular invasion, then it generally means it's a high-grade lesion that's behaving aggressively. So how does it compare with perineural?
I mean, perineural invasion is a soft prognostic indicator. There's lots of papers which say it's good, others say it's not, but basically some urologists tend to use it as a sort of non-nerve spare on that side. But there's probably no evidence for that at all. So it is pretty rubbish. As to the vascular invasion, again, it's pointless. It's not going to change the management of the patient. By that stage, they've got metastatic cancer. The oncologist is not going to sort of rub his chin and say, yes, that's really bad. It already is really bad based on everything else. So I think if you had a Gleason 3+3 and you saw vascular invasion, then it isn't vascular invasion. I think that's probably the take-home message.
Thank you. There is a question in here about radical prostatectomies, which we could perhaps address just now. It says, for radical prostatectomies, what would you recommend to leave out and keep in terms of measuring, estimating, and prognostic items? So I know that that's a big question. And it's basically, please repeat for radical prostates, but can you give a thought about that?
So for the radical prostates, we haven't given a tumor volume because it's not evidence-based. So there hasn't been very much change in the radical prostate section, really. It's introduced the percentage pattern fall, which I must admit, I have my doubts of its usefulness. It's introduced cribriform and introductal, but merge the two together, so you don't need to do basal markers. You can just say, yeah, it's the both, because the evidence suggests if cribriform and IDC have a very similar prognostication. For the radical prostates, you have to remind yourself that, in fact, I won't say it's completely pointless, but there's a degree of pointlessness in reporting lots of data on the radical prostate, because the most important thing for prognostication is the first PSA 6 weeks after surgery. That is the most important for prognostication, i.e. has the PSA dropped back down to undetectable. If it hasn't, then he's probably got metastatic disease, or they've my screen has just gone weird. Or they've got residual tumor which they haven't resected.
Yeah. Okay, thank you. Just to go back to BRCA, again, it's about the effectiveness of the technology when it comes to actually detecting these aberrations. So, do you have a time limit if for biopsy? So, for example, are you happy to use material that's 3 years old, or do you think that it makes any difference to the quality of results that you're getting? Given that most of those things are now set for FPP.
Yeah, I think there's we had involved in another call talking about this, and at the Southwest we have no cutoff at all. Any material, any age, we have a go. But I know in certain other centres it's 5 years or 10 years or something like that. But we found that our failure rate is probably the lowest in the country. It was last time I looked. So should be no restriction. And if they can't extract DNA, they can't extract DNA. We do still have failures, but we don't restrict the time limit of age of specimen.
No, I think it was originally 9 years, we were told, when they first started doing it, but that
was based on the original.
That
was based on the study that they found that there were significant failures after that age, but we're finding that if you're getting results 15, 20 years later. But I mean, obviously, there are not many patients who are going to live that long to a certain degree as well.
Okay.
We find ourselves looking at extremely old archival material trying to work out the percentage of tumours. So 9 years from now, people won't be having to do that because they'll have the percentage in the data set.
There is another question in about radical prostatectomies now, and it's about positive margins. Do we report them as greater than 3 millimeters and less than 3 millimeters, or should it be precise? And is it still linear and not block thickness if it's the same site in multiple blocks?
I mean, it's a very good question. The answer is we don't know. We personally do it in give a measurement, and but we've given you the opportunity not to do that by having just a simple more than or less than 3 millimeters. I would suggest that you're going to measure it to get to the greater than or less than 3 millimeters. So you might as well give that number that you've generated. It's probably completely pointless as a number, because, as I say, the most important test is the PSA afterwards. But the 3 millimeters has come in as a measure of quality for the urologists. So that's why it's there. It's used in their data set. So if it's a PT2 with a less than 3 millimeters, then that's okay. If it's more than 3 millimeters, that is a black mark in their scoring in the BAUS data set.
Okay, well, thank you very much. I think that's really all we have time for in the discussion today. I would like just to point out to participants that there's a recording of today's webinar, including the question and answer session, and that will be available on the college website quite soon once it's been edited and tidied up. So you'll be able to review that. And if you want to do that, that's fine. And if you've got any colleagues who weren't able to join us today, if you would please let them know that they'll be able to watch it on the website within the next few days. The Professional Guidelines team will also be sending out a short feedback survey, and we'd love to hear what you've thought about today's webinar. It'd be helpful for us going forward and for the presenters as well. So it really just remains for me to say thank you both to John Oxley and John Mitchard for their contributions today, and to the others who have been responsible for drawing together these guidelines, and to the team in the college for facilitating and running the webinar program for us. So please look at the webinar webpage and look and be ready to come and view and participate in future webinars. We've two scheduled in March, the first one on the 10th of March, which is around gastrointestinal pancreaticobiliary pathology, and then on the 19th, CNS tumours. With that, thank you all for attending, and I hope the rest of your day passes favourably. Thank you very much, and goodbye.